To invite Dr. Mahesh Shanmugam, a colleague of ours from Shankrai Hospital, Bangalore, who heads our Vitreoretina Ocular Oncology, and yesterday was recognized with the C.N. Shroff Award by the All India Ophthalmic Society. So, sir is going to be sharing with us the ophthalmic management. Cluster has happened, but the patient still is important. So, what are we going to do about the patient?
Thank you so much, Dr. Kaushik. So, let's look at ophthalmic management of cluster endophthalmitis. Essentially, it's the same. Ophthalmic management of cluster endophthalmitis patients remains the same. Actually, you treat endophthalmitis like how you would treat any other endophthalmitis patient, but then there are some differences. So let's look at a clinical example. Here we have a patient who has a hypopyon on the first day after an uncomplicated surgery. So usually a cataract surgeon tends to believe that it is TAS. So it's possible it's TAS. So but how do we differentiate a TAS from endophthalmitis is the first question that arises. So TAS, as all of us know, it follows an uneventful surgery, and it usually happens on the day of the surgery or the first day of the surgery. There is intense post-op inflammation, and the patient does not have much pain. There is fibrin in the antechamber, and corneal edema from limbus to limbus, and no vitreous involvement usually. But what we need to understand is that TAS can be a cluster as well. So endotoxin contamination of balanced salt solutions, as well as inadequate instrument sterilization and preparation, can give rise to TAS as a cluster. So that's something which we need to differentiate from a cluster TAS versus a cluster endophthalmitis. So let me give you an example. This happened to us. So it happened to only me. There were 3 of us in the vitreoretinal department, but in one particular theater, one particular machine, I used to do vitrectomy for macular surgeries, like a macular ERM or a macular hole, and fill up the eye with partial fluid air exchange, and then about a week or so later, the patient presented with intense posterior segment TAS. So the A in TAS is anterior segment, but then we used to have a lot of inflammation, vitreous membranes, as you can see here, in the posterior segment in these patients. So I was ripping apart everything to see what are the cause for this particular issue. I could not find anything. The sterilization indicators were perfect. Everything else was perfect. Then in desperation, I told the engineer to rip apart the machine. So if there was something wrong with the machine which is going on. So as he was about to rip apart, he pulled out this tray out here. So that had a filter through which the air from the OT was drawn inside and pumped into the eye during fluid air exchange. And this filter, this is how it looked. So this filter was supposed to be replaced, and somebody forgot to replace it. The engineer did not know that it had to be replaced. And this resulted in the posterior segment TAS. And all the patients where I had done a partial fluid air exchange were the ones who had this inflammation. So it's something which we need to differentiate a posterior segment TAS from, or an anti-segment TAS from an endophthalmitis. As I mentioned, it can occur as a cluster. So this is the tabular column which differentiates the two clinically. The TAS occurs much earlier on the day of surgery or on the first day. There's hardly any pain at TAS. Conjunctiva and lid are normal. That's a very important sign differentiating between TAS and endophthalmitis. Corneal edema is limbus to limbal in TAS, and iris has a dilated pupil in TAS in contrast to a small pupil in endophthalmitis. IOP is quite high in TAS. It can be high or low in endophthalmitis, and therapeutic response is very good to steroids. In contrast, in endophthalmitis, they worsen. And TAP is negative in TAS. Of course, it can be positive, and most often it may be negative as well. So we have a patient with first day hypopyon, doesn't all the time mean it's TAS. It can be a very virulent gram-negative organisms. So whenever we are doubtful, what I would do is to do a TAP and then inject an intravitreal antibiotic plus a steroid, and then look at the specimen and then take the subsequent treatment based on how the patient progresses or worsens. So as I mentioned, the first day post-op cluster endophthalmitis is a very bad sign. So it's likely to be a gram-negative organism, and studies have shown that most often it's Pseudomonas aeruginosa is the most common organism associated with the cluster endophthalmitis from India. And it's likely to be consumable related. So it could be an infusion fluid or a viscoelastic. So you are likely to get a lot more patients in the subsequent days coming up with this particular infection. And the other implications are they rapidly progress gram-negative organisms and with a high chance of loss of eyes. And if it is a gram-negative organism, in contrast to what the endophthalmitis vitrectomy study showed, we do give a parental antibiotic. It could be an IV antibiotic or a parental antibiotic is preferably given. And we have to treat these patients with intensive topical and intravitreal treatment and less threshold for early vitrectomy. So most often we jump in and do a vitrectomy in these patients to save the eyes. So what is the next step once we identify a patient with endophthalmitis who is part of a cluster, admit the patient, and most important, check vision. This is medico-legally necessary, always check vision. And next step is to perform antechamber tap or vitreous tap as soon as possible. And if fundus view is not possible, do an ultrasound to see how the status of the retina is and vitreous is. So these are all common steps for any endophthalmitis. And next is to obtain a specimen. Specimen is extremely important in this situation. I'll tell you why. So specimen can be AC tap, vitreous tap, corneal scraping, or an explanted intraocular lens. And then subject it to everything possible. Do a PCR to see if you are able to identify the bacteria, and then also do a smear culture, preferably in 2 labs, so that we increase the chance of identification of the organism. So what do? It's usually the same: grams, games, and fungal staining, culture, aerobic, anaerobic, and fungal. And it's preferable to plate the specimen in the OT itself. Let's not send it out of the theater, particularly if you don't have a functioning microbiology department in the hospital. Get the culture plate and put the specimen in, plate it into the culture media in the OT itself and send it out. So why is it necessary to identify the organism? Because it helps us to treat the other patients. And also it helps us to identify the source of the infection. Let me give you another example. In my previous place of work, we suddenly had a bunch of patients with fungal scleritis. Totally uncomplicated surgery, could be a macular hole. Diabetic patients tended to have a little bit increased incidence of the fungal scleritis. Nearly 40-50 patients, we suddenly found that we had fungal scleritis. Once again, we went around breaking our head as to what was the reason for it. Finally, I went into the theater and found that there was a gap between the false ceiling and the wall, and took a specimen from the top of the false ceiling and found it was Aspergillus flavus, which was the exact same organism which was found in the patients. So it's the identification of the organism helps us to identify what is the source of the organism, and also to treat the other patients as well. So how about medical management of endophthalmitis? It's essentially the same. Topical antibiotics. What is preferable is either a fluoroquinolone plus an aminoglycoside. Most often it's moxifloxacin and tobramycin or amikacin, half-hourly or hourly. Topical steroid if you are not suspecting a fungal endophthalmitis 6 times a day, and topical cycloplegic. Subconjunctival antibiotic I usually don't give, but you can give this in addition to an intravitreal antibiotic as well as a topical antibiotic, but not in lieu of either of the two. So you can give it in addition to. So vancomycin, ceftazidime, or dexamethasone can be given subconjunctivally. Most important is to give an intravitreal antibiotic. And it's essentially vancomycin plus amikacin. But what we most often give is vancomycin plus ceftazidime. It's a standard dose of antibiotics what is given. And intravitreal steroid, dexamethasone 400 micrograms is something which I would give in addition to the antibiotics. Other intravitreal antibiotic, because like in a cluster, it need not be an organism which is usually susceptible to the common antibiotics. So we may have to look at other antibiotics. So other intravitreal antibiotic which can be given are moxifloxacin, that's a dosage 100 to 200 micrograms, linezolid, piperacillin, tazobactam, or colistin. These are the other antibiotics which we need to keep in mind when we are managing a cluster. Antifungals can be voriconazole and amphotericin. These are standard ones, which is what we usually give. Systemic antibiotics, as I mentioned, in a cluster, I would prefer starting a systemic antibiotic. And if in case it's not gram-negative, turns out to be gram-positive, probably you can stop the systemic. But I would prefer to give antibiotic in every possible way in a cluster to manage these patients the best possible. And what are the systemic antibiotics which we give? Usually give it for 5 to 7 days. Ceftazidime, garamycin, amikacin can be given. Linezolid, vancomycin, imipenem, or meropenem can be given. These are parenteral, IV antibiotics. Oral moxifloxacin, gatifloxacin, trimethoprim sulfamethoxazole can be given orally. What is this based on? This is based on a study which showed that like best documented agents achieving therapeutic levels in vitreous are meropenem, linezolid, moxifloxacin, and acceptable are vancomycin, cefazolin, ceftriaxone, ceftazidime, imipenem, and trimethoprim sulfamethoxazole. But these are useless. So don't give ciprofloxacin, levofloxacin, aminoglycoside, aminopenicillins parenterally in a patient with endophthalmitis. Does not reach the vitreous to give a sufficient enough inhibitory dose. Oral steroids, if it is bacterial endophthalmitis, prednisone 30 milligrams a day for 5 to 7 days is what I would give. And vitrectomy, I would suggest an earlier vitrectomy, considering the implications, better chance of vision and eye salvage, and also helps us get a valuable specimen to identify the causative organism. So we may land up with eyes like this if it is a gram-negative organism. The first day, second day, cornea is opaque and then can't see anything. We may have to resort to a PK plus vitrectomy. So here we have done a 6 millimeter cannula, then open up the cornea and put the keratoprosthesis. And then you can see how it is inside. It's a gram-negative infection. How, like, the retina is almost all the time, like, it's gone, kind of. So the posteriorly, it's actually the vitreous cortex with a lot of exudation. And earlier days, we used to just do a core vitrectomy and come out, but like now we do a little bit more aggressive vitrectomy. As you can see, once the PVD is induced, you can see the posterior pole is reasonably healthy. But this patient had necrotic peripheral retina with the retinal detachment. So we had to cut the retina, do a retinectomy. That's the retina which is floating around in the periphery. Put perfluorocarbon liquid, reattach the retina, and put oil to reattach this eye. So other adjunct steps may have to be done along with vitrectomy, like removal of the IOL and wash the anterior capsule and wound resuturing. And as I showed, vitrectomy plus tamponade can be done. So do we use silicone oil in these patients? Usually not necessary in all patients, but like in this situation, we may use silicone oil a little bit more often because silicone oil is inhibitory to pathogens. And in a cluster, we probably use it a little bit more frequently because it allows fundus examination, early vision recovery, reassures the patient that eye is going to be okay, and treats and decrease the risk of retinal detachment. We want to take a little extra care in this patient. We don't want things going further wrong in this patient. So probably a little bit more use of silicone oil in a cluster is required. So there's the end result of the surgery which I showed. Follow-up treatment would be change antibiotic based on microbiological analysis, and intravitreal antibiotics are repeated every 48 hours. Less threshold for vitreous lavage or revitrectomy. If the vitreous is not clearing in the postoperative period, we go back inside and wash the vitreous and remove the inflammatory material collected. And the topical antibiotics and steroids are continued for the next 4 to 6 weeks. Steroids are tapered slowly, and frequency of antibiotic application is decreased over the weeks. So if it's an MRSA-resistant endophthalmitis, then we can give intravitreal vancomycin, and if it's a vancomycin-resistant endophthalmitis, these are the other agents you can use. Intravitreal linezolid, quinapistin, danfopristin, and daptomycin can be used. Fungal endophthalmitis, we repeat the intravitreal injections over a longer period of time. It can be 2 weeks or it can be even a month. And if necessary, I alternate. One day amphotericin B, the next day could be voriconazole. I alternate like this until the infection comes under control. Oral and parenteral antifungals are used for about 2 to 4 weeks. Last bit is about like povidone iodine. So you can use povidone iodine in the vitreous cavity. It's bactericidal, non-toxic, and the solution is effective for 15 minutes. So need to prepare a fresh solution every time you want to give it intravitreally. An intravitreal injection prior to vitrectomy has been studied in one study where they have given 1.25% of 0.1 ml, and 3 to 5 years before vitrectomy, they inject inside, they go inside and do a vitrectomy. But you can leave the povidone iodine in the vitreous cavity as a kind of an agent as well. So it's about like the dosage is 1.25 ml in 10% or 2.5 ml of 5% povidone iodine, which can be put in the infusion. And that infusion can be what you run through during the vitrectomy. At the end of the surgery, you can leave with 0.1 ml of 5% povidone iodine, and that can also be bactericidal as well. So to summarize, let's not presume that it is stars. Check vision, start prompt treatment. It's important to identify the organism, aggressive treatment, all routes of delivery of antibiotics if necessary, and lower threshold for vitrectomy, lesser threshold to use alternate antibiotics and povidone iodine. Thank you very much.